Bismillahirrahmanirrahim. Quote for the day is Allah says in Holy Quran, indeed, Allah will not change the condition of a people until they change what is in themselves. The topic for today's presentation is primary healthcare. I am Dr. Ayesha AminPGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my supervisor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. We will be focusing on the questions which have come in the past in exams over the years related to the primary healthcare. So there was a first question which was came twice over the year in 2022 and 2017 as well. It was stated that primary healthcare approach was adopted at Alma Ata for achieving the goal of health for all. Briefly illustrate the various components of PHC and write down the basic principles of PHC that are required for the success of your program. So first we will look into the definition of PHC. The Alma-Ata Declaration of 1978 defined primary healthcare or PHC as primary healthcare is essential healthcare which is based on practical, scientifically sound, and socially acceptable methods and technologies which is made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. The next is the type of PHC. There are two common types of primary healthcare. One is comprehensive primary healthcare, and the second one is selective primary healthcare. The essential components of comprehensive primary healthcare consists of 8 essential components or elements. The first one is education concerning prevalent health problems and their prevention. Number 2, promotion of safe food supply and proper nutrition. Number 3, an adequate supply of safe water and basic sanitation. Number 4, maternal and child health care, including family planning. Number 5, immunization against major infectious diseases. Number 6, prevention and control of locally endemic diseases. Number 7, appropriate treatment of common disease and injuries. And number 8, provision of essential drugs. So, the essential components of selective primary healthcare. The selective approach, comprehensive primary healthcare, was considered beyond the reach of most low-income countries, and selective approach was suggested because the targets which were set in comprehensive PHC were too ambitious and were difficult to achieve for most of the LMICs. The selective approach of primary healthcare was put forward by Walsh and Warren. It gives priority to certain diseases according to A, their prevalence, their morbidity or disability they cause. Third is their mortality, and D, then the feasibility and effectiveness of control measure and the cost of intervention. So the selective approach, it should aimed at children less than 3 years and women of childbearing age. This would result in significant decline in mortality rate in any area in which it is appropriately applied. It has 5 major components, and all of them are basically focusing on children less than 3 years of age and women of childbearing age. The first component was measles and diphtheria pertussis tetanus vaccination for children over 6 months of age. Tetanus toxoid for pregnant women to prevent neonatal tetanus, encouragement of long-term breastfeeding, chloroquine treatment during febrile episodes for children under 3 years in malarial regions, and provision of ORS and instruction for their use in the treatment of diarrhea. Then another selective approach, it was further altered by UNICEF, a selective approach which was proposed by UNICEF with emphasis on mother and child health was called GOBI-FFF, which means G stands for growth monitoring, O for ORS, B for breastfeeding, I for immunization, and F for family planning, female education, and female nutrition. So again, it supported the selective approach along with the family, female education and female nutrition. So, if we look at the status of primary healthcare in Pakistan, so in Pakistan, the primary healthcare has two important components. The first component is community component. The community component of service provision is through frontline health workers, which are lady health workers, LHWs, and community midwives. That involves primary preventive and health promotive services. And the second component is health facility component, which include the basic health units and rural health centers, BHUs and RHCs, which are currently converted into Mariam Nawaz health clinics, and then maternal and child health centers, MCHCs, and civil dispensaries. The maternal child health centers and civil dispensaries are often located in large urban and rural areas. So, secondary healthcare, it refers to the medical care that is provided by a specialist or facility upon referral from primary care, and that requires more specialized knowledge, skill, or equipment than the primary care professional can provide. So, secondary level health facilities in Pakistan include the Tehsil headquarter hospitals, that is THQ, and district headquarter hospitals, DHQ. The service provided here are primarily curative in nature. So, the purpose of discussing secondary healthcare is that in Pakistan, the primary healthcare and secondary healthcare, they both combine and constitute the district health service system. So, PHC in Pakistan is a part of district health service system. Now, coming to the principles or pillars of primary healthcare, the four important pillars of primary healthcare are community participation, equitable distribution, appropriate technology, and intersectoral coordination. So we'll look into the detail of each principle one by one. PHC reforms, the World Health Report 2008 shows that PHC now more than ever. So in 2008, the PHC concept of PHC was modified and new reforms were brought in. At 30th University of Alma Ata, the WHO revised the ambitious vision of PHC as a set of values and principles for guiding the development of health system and suggested four avenues for reducing gap in implementation, defined as four set of PHC reforms, and they now focus on the universal coverage reforms to improve health equity, service delivery reforms to make health system people centered, public policy reforms, that is integrating public health action with primary care by pursuing healthy public policies across sectors. And fourth one is leadership reforms, making inclusive, participatory, negotiation-based leadership. World Health Report 2008, PHC now more than ever slogan of WHO strategy on healthcare financing advises low and middle income countries to focus on a target of 30% of total health expenditure should be allocated to the essential health services and primary healthcare. So we'll now look into the detail of the principle and pillars of the primary healthcare. The first one is community participation. Community participation is a process in which community people are engaged and participated in making decisions about their own health. There is a social approach to point out the healthcare needs of the community people. Community participation involves participation of the community people from identifying the health needs of the community, planning, organization, decision making, and implementation of health programs. It also ensures effective and strategic planning and evaluation of healthcare services. A participatory approach ensures that the health interventions are culturally acceptable and tailored to the community's priorities. Encouraging ownership and empowerment within the community fosters long-term sustainability of health initiatives. In lack of community participation, the health programs cannot run smoothly and universal achievement by primary health care cannot be achieved. The second important principle is equitable distribution. The first key principle in the primary healthcare strategy is equity or equitable distribution of health services. That is, health services must be shared equally by all people, irrespective of their ability to pay, and all, either he is rich or poor, reside in urban or rural areas, should be must have access to health services. The principle of horizontal equity, that is equal treatment for equal needs, and vertical equity, providing more resources to those with greater need, would guide the allocation process to reduce health disparities. At present, health services are mainly concentrated in the major towns and cities, resulting in inequality of care to the people in rural areas. Primary healthcare aims to reduce this imbalance by shifting the center of gravity of healthcare system from cities where three-quarters of the health budget is spent to the rural areas where three-quarters of the people live, and bring these services as near people's home as possible. The worst hit are the needy and the vulnerable groups of the population in rural and urban slums. This has been termed as social injustice. The failure to reach the majority of the people is usually due to inaccessibility. Special focus should be given to the vulnerable groups such as women, children, and marginalized population to ensure that they have access to essential health services. Then the third important pillar is appropriate technology. Appropriate health technologies are an important strategy for improving the availability and accessibility of health services. It has been defined as the technology that is scientifically sound, adaptable to the local needs, and acceptable to those who apply it and to whom it is applied, and it can be maintained by people themselves in keeping with the principles of self-reliance with the resources of community and country can afford. Appropriate technology refer to using cheaper, scientifically valid, and acceptable equipments and techniques. It is also necessary to ensure that the technology is scientifically reliable and valid, adapted to the local needs, acceptable to the community, and accessible and affordable by the local resources. Example includes promoting the use of oral rehydration solution for diarrhea, locally available nutritious food for addressing malnutrition, and mobile health or mHealth solutions to improve healthcare accessibility. The fourth and the most important component is the intersectoral coordination. Intersectoral coordination plays a vital role in performing different functions in attaining health services. The involvement of specialized agencies, private sectors, and public sectors is important to achieve improved health facilities. Intersectoral coordination will ensure different sectors to collaborate and function interdependently to meet the healthcare needs of the people. It also refers to delivering healthcare services in an integrated way. Therefore, the departments like agricultural, animal husbandry, food industry, education, housing, public work, communication, and other sectors need to be involved in achieving the health for all slogan. So the declaration of Alma Ata states that the primary healthcare involves, in addition to the health sector, all related sectors and aspects of national and community development, in particularly agricultural, animal husbandry, food industry, education, housing, public works, communication, and other sectors. To achieve such cooperation, countries may have to review their administrative system, reallocate their resources, and introduce suitable legislation to ensure that the coordination can take place. This required strong political will to translate values into action. An important element of intersectoral approach is planning, planning with other sectors to avoid unnecessary duplication of activities. Sorry, the next question, which was came in 2023 exam, was also related to PHC. The primary healthcare approach is essential in achieving the acceptable level of health throughout the world. As a public health physician, how would you implement primary healthcare plans by following the general principle of PHC in a community? And the B part was enlist constraints in implementing primary healthcare in developing countries. So as far as the first part is concerned, we have gone through the general principles of PHC in a community. We will be now focusing on the constraints in implementing the primary healthcare in developing countries. So, implementing primary healthcare in developing countries faces several constraints, including financial constraints, workforce challenges, governance and leadership issues, service delivery challenge, access to medication and technology, health information system limitations, cultural and social barriers, and infrastructure limitation. We have divided all the constraint considering the building blocks of the WHO framework of health system in mind. So, financial constraints. Insufficient funding remains a major challenge, limiting the ability to provide comprehensive primary healthcare services. Due to financial constraints, government often opt for selective PHC, focusing only on specific health issues rather than a holistic approach. Dependency on external funding and inconsistent budget allocation further hinders the sustainable PHC implementations. Workforce challenge. There is a shortage of trained healthcare professionals, especially in rural areas. as most prefer working in urban settings, leading to inequitable service distribution. High turnover rates, lack of motivation, and inadequate training opportunities further weaken the healthcare workforce. Then, governance and leadership issues due to the political influence, those holding the authority of resource allocation are influenced by high level professionals towards large spending on sophisticated technologies in utter disregard to the PHC requirements. Bureaucratic inefficiencies, corruption, and weak regulatory frameworks lead to poor enforcement of health policies and strategies. Next is the service delivery challenges. Government struggles to provide direct healthcare services, especially when the population prefers private healthcare facilities. The presence of a mixed health system, that is public and private, which is seen in Pakistan, leads to the fragmented services, poor regulation, and limited government oversight. Weak referral system and lack of integration between different levels of care further affects the service delivery. Then, access to medicine and technology. Essential medicines and appropriate healthcare technologies are often unavailable, unaffordable, or culturally unacceptable. Supply chain inefficiencies, poor inventory management, and reliance on effective imported medical technologies contribute to limited access. Community participation in adopting new health technologies is often lacking due to inadequate awareness and training. The next is the limitation of health information system. Inadequate data collection, poor record keeping, and lack of reliable health information hinders the evidence-based decision making. The absence of standardized reporting mechanism results in inaccurate health data, which affects planning and resource allocation. And limited use of digital health technologies further exacerbate the information gaps. Then there are cultural and social barriers. The cultural belief, traditional practices, and resistance to modern healthcare interventions hinder the primary healthcare adoption. Gender disparities and lack of awareness further prevent certain populations from accessing essential healthcare services. And there are infrastructure limitations, poor health infrastructure, including inadequate health facilities, lack of transportation, and unreliable electrical supply, affect service delivery. Geographic barriers, such as remote and hard to reach areas, make healthcare accessibility very challenging. The next is lack of appreciation of multifaceted approach. Investment merely in health sectors are not conducive toward a healthy lifestyle. Lack of coordination among various stakeholders affects effective PHC implementation. And then political climate. In several countries, the allocation of not less than 40% of financial resources should go towards defense, 25 to 30% towards debt servicing, and 5 to 20% are reserved for non-developmental expenditures. Therefore, very little is left for development expenditures. And in such cases, health this assumes a very low priority. Unfavorable climate, particularly due to nuclear arms and race, had been a serious constraint in achieving the health for all goal in many countries. Then, disregard of human rights, ethnic violence, and social evil seem to be raging during current decade. This necessitates diversion of large amount of money to be spent on for maintenance of law and order by the government. So, then a question related to the primary healthcare recently came last year in exam, and it states that you are managing a hospital. For effective monitoring and functioning of the hospital, you have defined new few health indicators. The first question was, what are the KPIs? That is, what are key performance indicators? And write down the key performance indicators for primary healthcare. So first of all, we will see what are the key performance indicators. A key performance indicator is a variable for measuring the achievements of objectives. Indicators are measures that can be used to describe a situation that exists and to measure the change or trends over a period of time. The function of an indicator is to indicate the good or bad about that variable. An indicator can be qualitative or quantitative. So characteristic, a key performance indicator should be objectively verifiable, and it should be cream, that is clear, C for clear, and should be unambiguous. It should be relevant, appropriate for the measure. It should be economic, available at a reasonable cost, must be adequate, sufficient to assess the performance, NN stands for monitorable, and it should be amenable to validation. So KPIs for primary healthcare. Following are the important key performance indicators for primary healthcare. The first one is availability of healthcare. Second, accessibility of healthcare. Third, acceptability and quality of healthcare. D, social and economic indicators. 5, indicator for the provision of primary healthcare. 6, health status indicator. 7, infant mortality rate. And 8, maternal mortality rate. So the first one is availability of healthcare. Is defined as the ratio between population in various administrative units and health facilities and the health manpower available. The second is accessibility of healthcare. Percentage of population which is residing within 5 kilometers to 1 hour walk of the nearest trained healthcare provider. Acceptability and quality of healthcare. Proportion of immunizable communicable disease cases for which patient history reveals past immunization for the disease contracted. The social and economic indicators include rate of population increase and adult literacy rate. Then the next is indicator for provision of primary health care, which includes 3 further indicators, that is percentage of homes with children under 5 years of age or pregnant women visited by the community health worker in a specified period of time. The second is percentage of pregnant women who received antenatal care at least once, and it is calculated by number of antenatal contacts divided by the number of expected birth into 100. And the third indicator is percentage of children aged 12 to 23 months of age who are fully immunized. The next is health status indicator. It includes the percentage of children under 5 years of age who are malnourished according to the Gomes classification grade 1, 2, and 3. So number of children less than 5 years who are in grade 1, 2, or 3 divided by the total number of children less than 5 years of age into 100. The next is infant mortality rate or IMR. That is the probability of a child dying before age 1 expressed as death per 1000 live births. That is a critical indicator of population health. It measures the number of deaths of infant under 1 year age per 1000 live birth in a given year. So we can see the formula of IMR in which the number of infant death in under 1 year divided by the total number of live birth in the same year, and it is then multiplied by 1000. And the next is maternal mortality rate or MMR. The maternal mortality rate MMR is the number of pregnant or recently pregnant women who die from pregnancy related causes per 100,000 live birth, reflecting the risk of death during pregnancy, childbirth, or within 42 days of pregnancy termination, excluding the accidental death. So in MMR, you do not include the women who die from an accident. It is a key indicator of maternal health calculated by dividing the maternal deaths by live birth in a given period and multiply this by 100,000. So again, maternal mortality rate, MMR, total number of female deaths due to complication of pregnancy, childbirth, or within 42 days of delivery in a given year divided by the total number of live birth in the same year. And it is then multiplied by 100,000. So this was all about the PHC, which was important from exam point of view in regard to the questions that has been asked over the years in related to PHC. So thank you.
Okay, thank you very much. Number first thing is please stop the recording.
Yes, ma'am.
Okay. MCQs should also be the part of PSC. So